Hello everyone. Welcome back to the series of lectures in gastroenterology. Today we will start off with another very important topic, which is your inflammatory bowel disease. So let's begin. So what is exactly this inflammatory bowel disease? So as the name suggests, inflammatory bowel disease is basically a disorder due to unknown reasons. There is inflammation of the colon, not just the colon, inflammation of any part of the intestine. The two prototypical diseases which are categorized as inflammatory bowel disease is your Crohn's disease and ulcerative colitis. So let us look at both Crohn's disease and ulcerative colitis in a comparative manner. So first we'll start off with the epidemiology. So let us look at the age of onset. Ulcerative colitis basically occurs from the 2nd to the 4th decades and a 7th to the 9th decade. So basically it has a bimodal distribution. The first peak occurs at 20 to 40 years and the second peak occurs at 70 to 90 years. Crohn's disease also has a bimodal presentation and this also presents similarly. So when it comes to the ethnicity, it's more common in the Jews and it is least common amongst the Asians. So the female to male ratio is much higher in the Crohn's disease as compared to the ulcerative colitis, but both ulcerative colitis and Crohn's are more common in males. Okay, so very important is about smoking and OCPs. So smoking and OCPs have a higher odds ratio of causation of disease in Crohn's disease, but it's considered to be preventive and there is no increased risk in ulcerative colitis. So an easy way to remember that is that whenever you look at the small intestine and then you have the large intestine, okay, so anything that you take orally, so smoking or OCP use is going to affect the small intestine first. So you can just remember it like that. Smoking and OCP is more common with Crohn's disease. Crohn's disease more affects the small intestine, correct? And the other way around, appendicectomy is protective for UC. So the appendix is attached where? It is near the large intestine. So appendicectomy is more protective for UC. This is just a way of remembering. Okay. Then monozygotic twins have a higher concordance of Crohn's disease, up to 58% and 18% in ulcerative colitis. Then infections in the first year of life is a very important risk factor for inflammatory bowel disease. So 1.6 and 3 times risk of developing IBD by 10 and 20 years of age. Okay. So these are about the epidemiological characteristics of inflammatory bowel disease. So what are the take home points from these? IBD is basically more common in males. It is more common in the Jewish ethnicity. It has a bimodal presentation. The bimodal presentation has two peaks. The first peak occurs at the age of around 20 years and the second peak age of around 70 to 90 years. Okay. IBD is more common in males. Then smoking and OCP increases the risk of Crohn's disease. Appendicectomy is protective for ulcerative colitis. Okay. Monozygotic twins have a higher concordance in your Crohn's disease. And when it comes to infections in the first year of life, forms a very important risk factor for inflammatory bowel disease. Alright, so these are the most important salient points that you have to remember about the epidemiology of Crohn's disease. The only protective factor which has been found is vitamin D. So vitamin D is considered to be protective for both Crohn's disease and ulcerative colitis. Now let us understand the pathogenesis. Okay, so the crux of the pathogenesis is that there is interaction between the microbial flora. IEC is your intestinal epithelial cells and there is some amount of immune dysregulation. So the interaction between your immunity, your intestinal epithelial cells and the microbial flora is what is responsible for maintaining the normal homeostasis. So whenever there is a disruption in this supraorganism that we call comprising of the microbial flora, intestinal epithelial cells and immunity. So when there is disruption of any of this, then this can result in IBD. Okay, so this is basically the crux of the matter. So, very importantly, what you have to understand is that genetic susceptibility and environmental factors are the ones which play the most important role. So, in a genetically predisposed individuals, if they have certain environmental triggers, then if there is a disruption in this interaction which is there between your intestinal epithelial cells, microbial flora and your immune system, then you can have an inflammatory bowel disease. So, what are the environmental triggers for your IBD? So, the environmental triggers are diet and hygiene, okay, stress, smoking, antibiotic use, especially in the first year of life. Then, presence of enteropathogens like Klebsiella, E. coli, Enterobacter. So, all of these have been implicated as environmental triggers for IBD. Plus, you have a genetic susceptibility. So, what are the genetic considerations that you have to take? So, genetic causes of monogenic IBD, right? So, monogenic IBD means that there are certain genes where you can pinpoint and say, yes, this is the gene why you have IBD. Especially in which form of IBD? Very early onset IBD. VEO IBD. VEO stands for very early onset. Okay. So, very early onset IBD basically means the IBD that occurs in the neonatal age group. The IBD that occurs in the neonatal age group. And most of the time, this neonatal forms of IBD have a monogenic association. Monogenic means one gene you can pinpoint. What are those genes? They are interleukin 10 receptor, CTLA4 and NCF2. Okay. In the adults, often it is a polygenic predisposition. So, you can see that there are so many genes, right? Interleukin 23, JAK pathway, STAT pathway, NLRP pathway and so on. Right? So, in adults it is polygenic. There are certain genetic disorders with which IBD is associated. What are those genetic disorders? So, first one we have Turner syndrome. Turner syndrome is basically an XO chromosome. There is a loss of one X chromosome. Then Hermansky-Pudlak syndrome. So, this is basically enteropathy with platelet dysfunction. So, there is a qualitative platelet dysfunction in your Hermansky-Pudlak syndrome. Then we have your IPEX syndrome. Okay. So, we have your IPEX syndrome where you have immune dysregulation, polyendocrinopathy, enteropathy and X stands for X-linked. Right. So, this is a multi-system disorder where you have immunodeficiency, polyendocrinopathy, enteropathy and it is an X-linked disorder. Then certain forms of glycogen storage disorders can also be associated with IBD. Okay. So, the crux of the pathogenesis is that there are three main components that you have to consider. Alteration in the microbial flora, in the interaction with the intestinal epithelial cells and the immune dysregulation. In a genetically predisposed individual, when there are certain environmental factors, when this entire homeostasis is disrupted, you can have IBD. Okay, fine. Now, let us see the main differences between ulcerative colitis and Crohn's disease. So, first we will start off with the pathology. Okay. So, ulcerative colitis is a limited disease. Ulcerative colitis is a limited disease. Depending on the severity, you can have different areas of involvement, but predominantly ulcerative colitis is limited to the rectum. In 10% of the cases, there can be ileal involvement. And this is what we call as backlash ileitis, because from the rectum all the way it has gone backwards and involved the ileum. Okay. So, on the gross pathology, what do you find? You find erythema, ulceration, and there can be formation of pseudopolyps. And what happens is that the colon becomes thickened and there is loss of hostrae. Leading to a lead pipe appearance. So, this is your gross photo of ulcerative colitis. So, you can see that this is diffuse mucosal disease with broad areas of ulceration. These are your ulcers. You can see that the red patchy friable ulcers. Okay. There is no cobblestoning, there is no bowel thickening. Those are all features of Crohn's disease. Okay. So, the characteristic features that you have to remember is that this is a limited disease. There is erythema, ulceration, there can be pseudopolyps. formation and lead pipe appearance as well. So on microscopy, what do you find? On microscopy, you find this. What is this? This is nothing but a shallow ulcer. Shallow ulcer. And what are these cells? These cells are your inflammatory cells. Okay. What type of inflammatory cell? You have basal lymphoplasmacytosis. Okay. So in the basal area, there is more inflammation. Right? Then the villi are blunted. And very, very importantly, feature which differentiates it from Crohn's disease is that there is no granuloma. Now let us look at how it is different in Crohn's disease. Very importantly, Crohn's disease can affect any part of the GI tract starting from the mouth to the anal canal. So Crohn's disease can affect any part of the GI tract starting from the mouth to the anal canal. Crohn's disease can be associated with skip lesions, and the ulcers in Crohn's disease are linear or serpiginous. Okay. On gross anatomy, on gross pathology, you can find a cobblestone appearance, right? You can find a cobblestone appearance, and you can find mesentery which is creeping over your intestine. So mesentery is inflamed and creeps over the intestine, and this is what we call as the creeping fat sign. The thickened mesentery which creeps over the intestine is called as your creeping fat sign. Another sign is the hose pipe appearance of the colon. So let us look at the gross pathology here. Here you can see that there is bowel thickening. Bowel thickening is not seen in ulcerative colitis. It is seen in Crohn's disease, and this results in your hose pipe appearance. Okay. Then you can find some cobblestoning, right? Can you see here like a cobblestone appearance like this? So this is your cobblestoning pattern. And the ulcers are predominantly serpiginous. It is linear, it is serpiginous. Okay. When it comes to the microscopy, unlike superficial ulcers or shallow ulcers which are seen in ulcerative colitis, in Crohn's disease there is transmural involvement. There is complete involvement of the intestine. There is transmural involvement. And what is the clinical significance? Because of the transmural involvement, Crohn's disease is more prone to perforation. So let us look at the microscopic features. The characteristic feature here is that this basal lymphoplasmacytosis is not there, and you find these epithelioid granulomas which are found in Crohn's disease. Okay. So this is about your pathological differences between the ulcerative colitis and Crohn's disease. Now let us understand the clinical features and differences between ulcerative colitis and Crohn's disease. So the clinical features, we have just learned that ulcerative colitis is predominantly a limited disease and it's limited to the rectum. So the clinical features is proctitis. Proctitis means inflammation of the rectal and the anal canal. So how does proctitis present? There can be bleeding, there can be fresh blood pers rectum, there can be tenesmus, there can be hematochezia, there can be constipation. Okay, so there can be tenesmus, bleeding and constipation. Apart from that, since this is an inflammatory condition, any inflammatory condition has constitutional symptoms. So there can be fever, there can be weight loss, there can be fatigue. Okay. So on examination, you can have abdominal tenderness. And if there is constipation and if there is obstruction, sometimes this constipation can progress to obstruction, then the bowel sounds will not be heard. Fine. In contrast, in Crohn's disease, what are the clinical features? Crohn's disease predominantly is affecting the ileum. So you can have ileocolitis, right? So ileocolitis results in a right lower quadrant pain with a palpable mass. So Crohn's disease is one of the greatest mimickers of which disease? So it can be confused with TB because tuberculosis, abdominal tuberculosis can also present as a mass in the right lower quadrant. Apart from that, it can also mimic appendicitis, right? It can also mimic any malignancy. Why? Because it presents as mass per abdomen. So it presents as right lower quadrant pain, mass per abdomen. And it can also have fever, diarrhea and constitutional symptoms. Crohn's disease, since this is having a transmural involvement, it can have fibrosis and stricturing, finally leading to obstruction. And since there is a transmural involvement, it can also form fistulous tracts. Okay, the most common fistulous tract is that it can have a colovesical fistula. Apart from that, it can also have enterocutaneous fistulas as well. So the fistulas can open to the skin, the fistulas can erode into the bladder, it can erode into the vagina, it can erode into the anal canal as well. So Crohn's disease, the characteristic feature is that this can present as mass per abdomen, it can involve the ileum, and very importantly, it is more prone to fistulas and stricturing. Okay. Then the second form is there can be jejuno-ileitis, and this jejuno-ileitis can result in malabsorption syndromes. Then there can be colitis, and perianal disease is seen in 33% of the cases. Right. So 33% of patients can have perianal disease, which is characterized by fistula or abscess. They can also have gastroduodenal disease. Okay, so Crohn's disease can also involve the gastroduodenal portion, can cause pain, nausea, vomiting, and gastric outlet obstruction. What is GOO? It is your gastric outlet obstruction. Okay, so these are the major important clinical differences between ulcerative colitis and Crohn's. So ulcerative colitis predominantly causes proctitis and predominantly presents as bleeding per rectum. Crohn's disease is a great mimicker. It can present as mass per abdomen, mimicking appendicitis, TB. It can present with fever, weight loss, it can present with ileocolitis. It can cause fistula, stricture, it can cause perianal disease, and it can cause gastroduodenal symptoms as well. Let us look at the complications. So, a very important complication which is seen in ulcerative colitis. So, if ulcerative colitis patient presents with abdominal pain, always rule out toxic megacolon. So, when do you call it a toxic megacolon? When the transverse colon diameter is more than 6 cm. So, the transverse colon diameter is more than 6 cm. This is called as toxic megacolon. So, you can have a toxic megacolon and you can have constipation and obstipation. Hemorrhage is seen in 1% of the individual. In 15% of the individuals, you can find strictures. Those strictures is more common in Crohn's disease. If there is a stricture in ulcerative colitis, you always have to rule out malignancy. Okay. So, in an ulcerative colitis patient, if you are finding a stricture, always rule out malignancy. The complications associated with Crohn's disease include perforation, pelvic abscess in 30% of the cases, and obstruction in 40% of the cases. So, this is about the complications of Crohn's disease and ulcerative colitis. Now, let us understand the diagnosis. So, how do you diagnose inflammatory bowel disease? Right? So, common feature or a common diagnostic test which is for both Crohn's disease and ulcerative colitis is that they have raised ESR and CRP, because this is a chronic inflammatory condition. What happens to the platelet? They can have thrombocytosis. Okay, two other stool tests that are done are fecal lactoferrin and fecal calprotectin. So, these two are not specific, but they are mainly used for monitoring. So, fecal calprotectin levels can be used for monitoring. So, if it is during your treatment, if the fecal calprotectin is coming negative, that means there is a good response to therapy. Okay. Then, there are certain specific antibodies which are used for the diagnosis of IBD. So, IBD, ulcerative colitis, is P ANCA positive, and Crohn's disease has anti-Saccharomyces cerevisiae antibodies. ASCA antibodies is anti-Saccharomyces cerevisiae. Fine. Now, remember that Crohn's disease and ulcerative colitis are biopsy findings. So, ultimately you have to do a colonoscopy and do a biopsy and correlate it with the symptoms, signs, and the other laboratory features. So, this is your colonoscopic finding of ulcerative colitis, where you see the presence of ulcers like this, red friable ulcers. Okay. This is in Crohn's disease, where you are seeing this kind of polyps. Okay. You can find some kind of polyps, and you can also find some kind of cobblestoning as well. This is your barium radiographic studies. Okay, your barium enema and barium radiographic studies, which are not done anymore because we have MRI, we have CT, which is more specific. So, certain findings which you should be knowing which can come as spotters. This is your lead pipe appearance of the colon. Can you see your lead pipe appearance of the colon with loss of hostrations? Okay, this is what we call as the string sign. Can you string this string-like appearance? This is basically a stricture or narrowing of the ileum. So, this is what we call as the string sign, which is very specific for Crohn's disease. And the most important test that we do, a very specific test, is a CT or MR enterography, which is now being replaced, which is now replacing your barium study. Okay, so this is about the various investigations that we use in the diagnosis of inflammatory bowel disease. So now let us look at the extraintestinal manifestations. So the first extraintestinal manifestation that we should be looking at is your rheumatologic manifestations, which includes your peripheral arthritis. So the first rheumatologic manifestation is your peripheral arthritis. So IBD associated arthritis is classified as a seronegative spondyloarthropathy. Now this is again classified into two types. So we have type 1 and type 2 IBD associated arthritis. Type 1 associated arthritis. Type 1 is basically more of an asymmetric migratory arthritis, which involves the large joints, and it is an oligoarthritis. That means what? Oligoarthritis means less than equal to 3 joint involvement. It is asymmetric. It does not involve both the sides at the same time. It starts in one joint on the right side, and then once it completely settles down, it is migrating to another joint, and it predominantly involves the large joints. Now, type 2 arthritis is different from type 1 arthritis in the sense that this is more symmetric. It involves both the left and the right hands or legs at the same time. Okay, this is a symmetric arthritis. It is more aggressive, and it is a small joint arthritis, and it is a polyarthritis. It involves multiple joints at the same time. So this is the basic difference between your type 1 and type 2 IBD associated arthritis. So IBD associated arthritis is an extraintestinal manifestation. Type 1 is large joint, migratory, asymmetric, oligoarthritis, whereas type 2 is small joint, symmetric, polyarthritis. Okay, fine. One thing that you have to notice is that everything that has been highlighted in pink means that it parallels the bowel activity. So peripheral arthritis is a manifestation that parallels the bowel activity. So treatment of peripheral arthritis can include treatment of underlying ulcerative colitis or Crohn's disease. So if the IBD is flaring up, that time the arthritis can also flare up. Then another important rheumatologic manifestation is your sacroiliitis. So what happens in this sacroiliitis? You basically have involvement of the SI joint. You have inflammation of their sacroiliac joint, which can present as severe lower back pain. Okay. Next we look at your bone disorders. So both Crohn's disease, ulcerative colitis are chronic inflammatory conditions, and hence you can have bone disorders which accompany them. So chronic vitamin D deficiency can happen and can result in osteoporosis, and they also involve treatment with steroids. So this can result in osteonecrosis as well. Then we look at the dermatologic manifestations. The most important is your erythema nodosum. Erythema nodosum basically refers to your painful lesions, slightly elevated lesions or papules which basically occur over the shin. So this is your painful erythematous papules which occur over your shin is called erythema nodosum. Erythema nodosum you would have also heard. It is also seen in tuberculosis. It can also be seen in sarcoidosis. It is seen in IBD as well. Since it's highlighted in pink, this also parallels bowel activity. So if the severity of there is a flare of IBD, there can be erythema nodosum as well. Then you can have something called as pyoderma gangrenosum. So for pyoderma gangrenosum is basically a devastating disorder where you have a necrotic, almost necrotic skin lesion. Okay, that's why it's called pyoderma gangrenosum. It does not correlate with disease activity. So treatment can involve oral steroids or even intralesional steroids. Then you have pyoderma vegetans, which is similar to pyoderma gangrenosum, and it is seen in the groin. Then you have Sweet syndrome. Sweet syndrome is nothing but neutrophilic dermatosis. It is neutrophilic dermatosis. Then you can have aphthous ulcers in the oral cavity as well. Now, erythema nodosum, pyoderma vegetans, Sweet syndrome, aphthous ulcers, all of these parallel to your bowel activity. Fine. And Sweet syndrome, aphthous ulcers are self-limiting. You just give conservative treatment for that. Then let us look at the ocular manifestations. The ocular manifestations include episcleritis and uveitis. So, episcleritis parallels your bowel activity. Fine. Then hepatobiliary manifestations include fatty liver, cholelithiasis, very importantly primary sclerosing cholangitis. We had learned this in the autoimmune disease of the biliary tract. Okay. What is the characteristic radiological finding? You find a beaded appearance. You find a beaded appearance. What is the characteristic histologic finding? You find your onion ring pattern. Onion ring pattern. Okay. Fine. What are your renal manifestations? It's associated with formation of calcium oxalate stones. Apart from this, thromboembolic events, cardiopulmonary diseases, ILD, endocarditis and myocarditis can be one of the extraintestinal manifestations of IBD. Then you can have secondary amyloidosis and pancreatitis as well. Okay. So this is about the huge list of extraintestinal manifestations which are seen with inflammatory bowel disease. Okay. And why this ILD in IBD is important? Because this is about the various extraintestinal manifestations of IBD. Okay. Now let us move on to the management of inflammatory bowel disease. So first we will be looking at ulcerative colitis. So in mild to moderate ulcerative colitis, you start off with what we called as 5-ASA. Okay, this is nothing but your mesalamine. It is a drug which is a sulfa drug, mesalamine, which can be given oral or rectal. So the aim is you control the inflammation. But in Crohn's disease, there is no role of mesalamine. So very, very important. This is used in mild to moderate ulcerative colitis alone. If there is no improvement, as you can see, this is a pyramid, then you go on to budesonide rectal or oral and your hydrocortisone rectal, which are nothing but steroid enemas. So steroid is an anti-inflammatory agent, it will bring down the inflammation. If there is no improvement with local therapy, then you give prednisolone oral therapy. No improvement with that, then you go to biologics. The biologics which are used are TNF inhibitors. TNF inhibitors like your infliximab. Right? These will help in your IBD associated arthritis as well. If there is no improvement with that, then on top of the pyramid we have your JAK inhibitors, which is your tofacitinib. So if you look at moderate to severe ulcerative colitis, it doesn't have mesalamine. You start off itself with oral steroids. So if it is a severe form of ulcerative colitis, severe form means more than 6 stools, blood-stained stools per day, or the patient is in shock, or if he is having continuous bleeding. Right. So if the patient is having severe ulcerative colitis, there is no role of local therapy. You start off with oral prednisolone directly, then hydrocortisone or solumedrol is methylpetrosolone. You give it IV at a high dose of about 1 gram. Then you go to biologics, and tofacitinib, cyclosporin has also been tried. Okay. Fine. Now let us understand Crohn's disease. In mild to moderate Crohn's disease, again there is no role of mesalamine. We start off with budesonide, then we have sulfosalazine, prednisolone and biologics. Right? In moderate to severe Crohn's disease, prednisolone, hydrocortisone and biologics. Okay? TNF alphas are not used much except in fistulizing Crohn's disease, where TNF inhibitors can be used. Okay? If there is a fistula, very, very importantly, you have to intervene, give them antibiotics and do an abscess drainage. Okay, so the major drugs which are used in ulcerative colitis are mesalamine, steroids, and then you have your immunomodulatory drugs. In Crohn's disease, it is predominantly steroids. And then you have your immunomodulatory agents. Newer drugs we have your anti-TNF or your TNF blockers, which includes your adalimumab, infliximab. Then we have your anti-1223 inhibitor, which is your ustekinumab. Then a newer drug, which is your alpha-4 integrin blocker, which is used, is your vedolizumab. So these are newer agents which are used in the management of inflammatory bowel disease. Now we have looked at the medical management. Let us understand what are the indications for surgical management of inflammatory bowel disease. So what are the indications for surgery? In ulcerative colitis, if it is an intractable or fulminant disease, if there is toxic megacolon, if there is perforation, hemorrhage, dysplasia, whenever there is dysplasia, you will have to remove because there is a high risk of transformation to malignancy. So these are all the indications for surgery in ulcerative colitis. In Crohn's disease, if there is a stricture, if there is a fistula, abscess, again if there is a dysplasia, you have to operate. Right? So whenever the ulcerative colitis has been severe and it has been there for about more than 8 to 10 years, then you have to do an annual or 6-monthly colonoscopy to rule out dysplasia. Because there is a high risk of colon malignancy with UC. Apart from that, UC is also associated with other malignancies like NHL, myelodysplastic syndromes and leukemias. Okay? So this is about your IBD. So till now, just to recap, what all have we learned? We have learned about the pathogenesis, the risk factors, how does the clinical features differ in ulcerative colitis and Crohn's disease. Then we have learned about the pathological and differences and the microscopic differences. And we have learned how the treatment differs as well. Thank you.